So in the next part, we will just try to lay down some principles of advanced care planning, which actually only last week in Europe they are talking about not advanced care planning but future care planning. And that was very interesting for me, for coming from a faith perspective. This is what we should be doing anyway. We should not be waiting for cancer or a disease to hit us. And again, I'm not asking for any answers here, but please let's think about ourselves. How many of us actually have written a will? That's what we should be doing. We should be not be waiting when we get, like I'm old anyway, but too old to write that will down. We need to be doing that, and we need to be encouraging, and we need to have again, the leaders are here, we need to have an active drive in our communities to write wills for that reason. And that, health aside, we should be thinking about it ourselves. How are we going to prepare without having a will? That's my personal faith tells me that I shouldn't be doing that anyway, whether I have got ill or not. Advanced care planning is the type of that. But there are some principles. I won't go through too much slides, but basically, we have to remember what it is. So we heard about living wills, we heard about people signing their DNA CPR form, so I need to just talk about that. First of all, it's a voluntary process. We cannot force people to have it. We should encourage them to have it, but not force them. And there is a reason behind it. Because we're talking about advanced care planning in the face of a life-limiting illness. And in assisted dying debate, this is what I was presenting all the time. When you are presented with widespread cancer or something, and your autonomy is supposed to be practiced, I argue that your autonomy is compromised. Because how many of us will be delighted and ecstatic if we are told that we have got only a few months to live? You'll be terrified. You'll be depressed. And you will be running away from everything. And this is where, if you now think, let's do advanced care planning. Evidence tells us that when the patients are diagnosed, where do you want to die? In the beginning of the disease, this number of much number of patients want to die at home, die in the hospital, and this much number of families want them to die in the hospital. As the time goes, evidence tells us this goes like this. So people now want to die at home, and their families want them to die in the hospital. That shows the mismatch. And the mismatch is because of the psychological pressure they are under now. Nothing else. This is why they said it's voluntary, but I think we have missed the boat. We want to discuss with those people who have got mental capacity, and this is another important concept. Again, how do we reconcile it from the faith as compared to the country's laws? Mental capacity is basically, I have got full capacity to make decision for my care. In 2005, they made this law, Mental Capacity Act, and has been revised 3 times now. Basically, if a patient has got capacity, my body, I can make every decision for me. Without asking, just speaking with a clinician, I don't need any family or community to be involved. And as the time has gone, there is clear recognition, patients do feel under pressure. Just because they say they have got capacity does not mean collusion does not happen. And I will talk about collusion later on when we talk about assisted dying. Mental capacity, we talked about DNA CPR, so let me take that now. Patients can have got a right, according to the law of the European Union as well as UK, they have got a right to refuse treatment. They do not have a right to demand treatment. That's a very important legal practice. So if I were to say, do not put a tube in me, I can write that, and a doctor should not be able to, or cannot do that unless they can overrule it through the courts. But I cannot say, put tube in me. If I did that, doctors can overrule it. That's the law in this country. So this is what the tension I was talking about earlier. that we actually say, well, actually, I do not want you not to do this type of treatment, and let me be clear, say CPR. Muhammad Abbas is sitting here, you have to do CPR on me. Muhammad said, well, actually, I don't have to, because it's my decision. I will. But I can tell him, do not do CPR on me. And according to the law of the country, that's what I'm saying. And then he cannot, because by law, it was taken as a battery, that he's beating me up, in other words, assaulting me. So my family can take him to court. And I have been in these situations, couple of times at least, at a very serious level, when doctors were thrown out of register, and one doctor actually was sent to jail for doing a CPR against patient's choice for only 3 months, but it was. So we have to be clear that there's some laws and regulatory frameworks we have to understand and come from there, obviously, and then navigate our own mindset according to the Sharia that we have. But whatever we do, this is the reason it came out. It has to be person-centered. And in my opinion, faith as well, it does empower people. It does create that confidence when we are having a person-centered discussion. If people we think of who actually were in the family and who were going through a difficult time, and we start talking about where do you want to be buried? How do you want the funeral to be like? And I remember having this discussion with my mother, and she said, if I die, so we come from a small town, if I die there, just bury me here. If I die in Karachi, bury me. If I die in UK, bury me there. I do not want to be transported, full stop. That was a clear instruction. And I remember she felt so good just saying it. And that's what we followed afterwards. But the point is that she actually valued that discussion more than any other discussion towards the end of her life. That where the funeral we should be, where should we want to be buried. So somehow people think that it is a difficult discussion, and I can tell you, hand on heart, I was dreading that discussion. Oh my God, I'm going to ask that. And I remember my mom, like, her eyes opened up, and she said, yeah, that's what I wanted you to ask. Because I was really worried about it. But I could not tell you because I did not want you to be feeling pressure for me saying it. So sometimes we are protecting each other. And this is why patient-centered discussion is important. Sorry, sister. That's what I was saying. We need to write the wills before when we get on.
We don't know. I might be in an accident today, and I don't have someone who can make decisions for me. So we don't have to wait till someone's ill or they're dying.
Yeah.
As a family, should discuss where we want to be buried, give capacity to people to make decisions for us before something happens, not after you be told you're dying.
Definitely. Thank you so much. Very good point. And this is why it's an ongoing process over our lives, not just after the illness. No, thank you so much. And we forget that we have not just, it is good, it's a duty on us that to understand where we are. And I will heavily encourage community and the leaders to put in a structure. See.
Excuse me. As an Islam. So just about this transport of where the burial, is it Islamically correct to bury it where they are died and as soon as possible rather than wishing somebody to take him, so for example to Kenya or whatever where you originally come from?
Okay, so I'll answer that question now before I give my comment about the will. In general, if a person has a specific will, that they want to be buried in a specific cemetery or in another city, the will itself would be okay. However, nowadays there is one problem. According to international laws, if a body is transported from one country to another, they have to go through embalming the body, and Ayatollah Sistani doesn't allow that. So the issue of being buried in another place, if people want to go to Karbala, for example, to be buried, in by itself it is okay, but because of this secondary problem that we have, that the body cannot be transported unless they go through this process of taking out the blood from the body, that becomes a problem. The reason I just interrupted you, sorry, the issue of will has come more than once. Although in the Sharia making a will is not wajib, but remember we in the West, our situation is different. If you lived in Pakistan or Iran or even in India, a secular country, there when it comes to the personal law, marriage, divorce and inheritance, even the secular court will judge according to your own faith. And therefore, there's no emphasis there to write a will about the division of estate and things like that, because it will be taken care of anyway. But in the western part of the world, the state gives you the right to write whatever you want to write in your will. And by not having a will, you are actually creating two problems. Number one, if there is a dispute among your heirs, they will end up going to the court, and the court will decide according to their own standards. And maybe the heirs will be ending up getting less or more than their share, and those who got more will become, for them that will be ghasb. And so, and that's why although initially it's not wajib, but by looking at the consequences, I would say it is wajib to write a will. You don't have to wait to become old. Anything can happen. There is no time. Nobody has given us any deadline. But writing a will in this situation, it is absolutely necessary.
I'll just quickly touch on this before we take on the question, which sounds much more meaty than talking about the topic itself. I just want to explain what are the components of advanced care plan or future care plan we should take benefit of. One of the clinical worlds, you talk about treatment escalation plan. So what is the highest level of treatment you should be receiving? And that's what we should be discussing with the patients. And it's actually legally enshrined now. The DNA CPR and withholding and withdrawing treatment, if we were to make a decision in partnership with the patient, it's legally enshrined. So basically it covers us, provided it is done in a proper way and signed off and everything. Advanced decision to refuse treatment is the most contentious thing. People make up their mind, they sign it, and the patient comes to us, and we cannot really overrule it unless we get a court order. So when we heard earlier about the people actually sometimes refuse the treatment and whether they can be sectioned or not, that in itself means that we have to kick off the legal jurisdiction to overrule an advanced decision to refuse treatment. And there have to be very good reasons for that. And I personally, I said earlier, lasting power of attorney to me, we should be encouraging as well in the community. And there's a reason which we'll talk about when we talk about assisted dying later on. Because there is, okay, I will not give too much away, but assisted dying bill is based on autonomy. You ask, I give, you die. That's what they think assisted dying is as simple as that. And we know from experience, if you look at the assisted dying law, the first time it was legalized was just after the First World War in a country. So it is not a new thing. It has been debated for more than 100 years. But over the century, we have seen that people practice. So not just you asked, what about you don't ask? But I give you because we decide this is the right thing for you to have. That's called non-voluntary euthanasia. Leave that out. In the law, what has become practiced in the past, You don't even ask. You are saying, actually, don't give me that. But we decide that actually it's good for you to have euthanasia. Sorry, I'm pointing. But not you, but could be you or you. That it's good for us as society and the custodians of care, that this is the right thing to do. That was made a law as well. And this is what we are worried about on a secular level. So faith-wise, they know that we'll be against it, but when I make my arguments, this are my arguments. We know this is slippery slope. Where do we end up? So to prevent that slippery slope, to me, lasting power of attorney becomes important. I need to find somebody who understands my values and my judgments, so that when I lose my capacity, my wife, or like I had for my mother, she never needed it, but I hope that she trusted me that I had the same values. So I was always, so when she would have lost capacity, I would have become the patient. So I would have made it known what is I really want to happen. So in advanced care planning, to me, if I can take one message out and try to apply it in our lives, that's lasting power of attorney.
Does everybody understand what power of attorney means? Because it's sometimes a medical phrase. Would you mind just explaining it again, just very quickly?
So power of literally is, if I lose capacity, that person can make decision on my behalf. There are two types of it. Have I written that? No. One is welfare, one is financial. Financial is for money making, like where my state goes and everything, so that they can operate my bank accounts and credit cards. But welfare is my healthcare decisions. I want to stop the treatment, or in some ways I want to discuss the treatment at least. They need to come and speak to their power of attorney, because before they made any strong decision. Even I want to put a catheter in a patient who has lost capacity. They need to have consent from that power of attorney rather than doing it. So this actually helps your values to be protected. This is where it's important. And then there are advanced statement, where do I want to be in the last days of life, and organ donation. That do I want to donate any organ when I die, and how, which organs, and you can specify, I want this organ to be donated, but not that organ to be donated. In United Kingdom, in England and Wales, it became a law of opting out. Have you heard of that? So now everybody is presumed to have the consent that they can take organs out if they are fit enough. So if you want not to donate your organs, you need to write a document beforehand. And the question is that, what is the mental capacity? Mental capacity simply is that my capacity to make a decision and weighing what is right and wrong, what is good and bad for that decision. For example, you come in and you decide that I need to have a procedure done on me, need to put a tube in for my breathing. If I have capacity, you cannot do that, meaning I've got I'm alert and can weigh the pros and cons, then you need to tell me what you're going to do and I will agree to it. That's mental capacity. If I lose that, then it will be either done by the doctors in my best interest, or your lasting power of attorney going back there can come in and doctors will have to speak to them about this. So one of the discussions which we were having earlier is the definition of death. So I will leave the Shari definition of death aside, but this is where the law stands in the different parts of world. In United States became the first country to identify brain death as the death point. So if the clinicians decide that under the UDDTA, which is Uniform Determination of Death Act, that this patient is brain dead, then they give a given period of time. It's different in different countries. Here it is 3 days, and other countries have different criteria. After that, they can switch off. The term was used, pull the plug earlier. But this is where they will say their duty stops, and they will have to do it by law. If the brain death is on, say, Monday, by Thursday they have to either do it or reverse the brain death decision. That's the law there. After USA, UK Academy of Royal Colleges also recognize that this is where this 3 days come. So in this country, if you are brain dead, then basically you 3 days is the minimum. You can go longer than that as well, but you have to document the decisions that day 1, day 2, and now we'll be stopping. So when they have that discussion, I will argue they should have those discussions way before they are even deciding it. So there's a different point to that, but that in law it is recognized as a death point, after which they just wait for the heart to stop. There are some other countries who have also recognized it. Very interestingly, Saudi Arabia recognized brain death as well in their law. So if in their ITU, if the patients are brain dead, then they have got rules and regulation in which it can be stopped. But they have nominated individual hospitals where it can happen, not everywhere. So they believe that where they have got full specialist team who can make these decisions, they will do that. And the other one is, I think it was Israel as well, which I haven't got here. Yeah, Saudi Arabia, China, Russia, but also I believe it's Israel. And the reason it is there, these countries have, is for the purpose of organ donation. So after you are declared brain dead, then you can extract the organs from the body at that particular time. This is where it is kicked off. So this is where the definitions are different. So we just talked about treatment, lasting power of attorney, which I said earlier, to act as patient, inform the system of the patient choices. This is what they need to do. And just some information about organ donation.
Dr. Syed, can I ask you a question?
Please.
Since you talked about, organs can be taken after the brain death, I read somewhere, I'm not sure, it's not my area of expertise, but sometimes I question the move of defining death from heart to brain. Was it purely a scientific decision, or was it looking at the issue of harvesting or procuring organs from the bodies? Because I know this much, that if the organs are taken after brain death and before heart stops, the quality is much better. But as soon as the heart stops, very rapidly the quality of the organs go down.
Very right.
So is
Thank
that
you.
a political
Thank
decision, moving from heart to brain, or really a scientific decision?
Okay. My personal, it's that's a different. It is more than the organ harvesting. Let me be blunt and call a spade, and I have done that hopefully most of my life. So I'm just saying it very clearly. Yes, that the second part of just being it be commercial is true, because we have got limited number of ventilators in the world. That's the bottom line. And but to be fair to the system, they said actually, what does the evidence tell us that when the patients have reached this stage, are they likely to recover or not? And I'm not saying the evidence is right or wrong, but the available evidence to them was that no, they don't. So they said, okay, so how can we get our ventilator free much more rather than the organ? It was more about how do we continue providing the good care to more number of patients, because we need these ventilators free. So we need to have an endpoint for this ventilator, which is based to us, available to us based on this information, which is available today. Now, what you can argue that evidence is changing. So for some diseases, for example, I talked about will you be surprised if this patient is to die within 1 year? One thing which changed it dramatically, and I do not know if you have heard of it, is immunotherapy. Immunotherapy. So firstly, when we gave immunotherapy, if there is any oncologist in the room, they will remember that it used to be we suppress the immune response so that the body did not make extra cells of cancer. Now we have got something called immunomodulation and immunoenhancers. And all of this put together is basically give you less side effects and makes you live much longer. So what happened? That evidence went out of window. Since they decided about brain death, that this is the evidence we have got, there have been certain movements to say we may, after brain death, it may need to be more than 3 days now. That's what they're talking about. So evidence is still coming out, but going back to the why the decision was made, that was mostly made, as my reading has been and my discussions have been with the hospital top teams, is that they needed to free the ventilator beds. Very crude answer to give, very uncomfortable to hear, but that's the reality. So very quickly, you know what is the living. We can all donate this when we are living. We don't need to die before. One thing I missed out on was skin as well. You can donate when you are living. But these are from the deceased people. And actually the list is getting longer. I wish somebody could donate the brain as well. But not yet, we have found. But these are the deceased organs. Just for your information, I thought it would be important to put on the screen. Thank you.
Excuse me, Dr. Qamar. Sorry, Madhwas. I was just saying the organ donation. Do we all not need to check what our merge is saying about organ donation? Because I don't know if Ayatul Sistani allows organ donation.
So that's why I put the screen there, and now the discussion will. Good. So we'll do that now. Maybe you.
There is some space later where we will be touching upon it, inshallah. Not fully, because it's a topic in and of itself, but I think we'll do enough to hopefully answer the questions. Thank you so much. What an amazing session that was. 2 sessions. We have questions on the slider, but if you decide to sit at the front, then you can just take the mic and ask questions directly and skip the queues. And that's what Maulana Sahib will do. I'm going to just very quickly summarize a few points and then come through it. I think when we talked about the bad news and communication skills, one of the key things that we learned was the importance of that open to closed question method. So starting with open questions, going to close, and really trying to determine the ideas, concerns, expectations, something we teach our trainees, but again, really important. And of course, when we talk about advanced care planning, one of the key things to look at, which will address some of the questions that were asked on the Slido, is that patients have a right to refuse treatment, but they don't have a right to demand treatment. Now, that's an interesting element for us as well as practitioners, so I'm sure there'll be some points. The last thing before we open up for questions is this very amazing observation that we see in palliative care, and it's something that certainly I learned a lot in the time I did it as a GP trainee, was that actually patients and family members really feel much lighter and happier when we have the conversation about advanced care planning, even though we're often terrified to ask those questions. And even if you're a senior consultant and you have the same experience, we have those anxieties. We're human beings. But actually, the quote, "She felt so good asking and saying it," is stuck with me. So please feel free to do that. Any questions, please raise your hand, but first to Maulana Sahib.
I have a question for Dr. Sahib. I don't know whether the answer would be there or not, but just an observation. If we go back to this issue of the changing the definition of death from heart to brain, if this commercialization of organ was part of the motive, if we advance more in the medical field and go through to a higher level of therapeutic cloning, producing cloning organs, so that need for retrieving organs from the bodies will go away. So then would this definition, is it possible that the definition of death will change again?
Hard to see in the future what happens. I think just starting from the point of view of heart to lungs, heart to brain, we also have to remember that the treatments have actually improved so much, so have the technology. If the type of ventilators we are using the same word as, if I say ventilator, I bet 90% of the doctors will have the same definition for a ventilator. Ventilators are different as well. And when we are talking about ventilators, the type of ventilator when I was in cardiology, nobody uses them anymore. Because we are much better in using the equipment which can pump at, previously it was a given drive. So I will pump so many liters of oxygen in your lungs. Now it actually adopts you. So basically most ventilators will be able to pump the same amount of blood for me as my body is doing now, but different for Maulana Sahab and different for Abbas. So we will be, so it's much more, so that is why it is keeping you longer alive on those ventilators, because it's my lung but outside my body. It's my heart but outside my body. But all it is doing is pumping heart and making lungs swell up. That's all it is doing. What it is not doing is actually reversing the brain activity, if it falls there. This is where we have not moved in terms of technology. We are still here. So this is why then they said, well, actually, the reason we need to change it as well, because if I put somebody on ventilator, you can do that for 100 years, because it's just not going to change. So this is where the problem is. Definition, again, I'm not talking about Sharia, I'm just talking about the clinically. We know it's my heart and my lung, but just outside my body. That's why it is pumping, and that's why they changed the definition to say, but something has gone wrong. You're not never going to wake up, are you? So this was the reason.
Thank you so much. We have a question from Dr. Shabir Morali. If you could just say your name that I just said.
Assalamu alaikum. I'm Shabir Morali. I'm a GP here in Northwest London and the Stanmore Palliative representative. So to give the context and background, I was born and brought up in England, studied medicine in England, and possibly my cultural background, my studies have contributed to my current health beliefs. I'm a big advocate for, as a GP especially, but also within sort of community, for advanced care planning, for providing autonomy to people for their own health and their own lives to a certain extent. And you know, we're talking about encouraging these conversations early on, before that capacity could be clouded, which I think is really important. But on the other hand, I'm starting to feel conflicted now with the Sharia advice, in that you're saying that we are limited in what advanced decisions we can make about our health, because earlier you said that we are not allowed to refuse treatment that is available to us if it could limit our life, for example, peg feeding. But even to the topic of resuscitation, we are not allowed to refuse resuscitation. So on one hand, we are encouraging autonomy to the person or the patient, but on the other hand, we're taking it away from them according to our Sharia, which for me is very uncomfortable and conflicting, and I'm just trying to balance that. And if we can explore that a little bit and have that conversation.
I think we have to realize that when it comes to Islamic or the Sharia perspective, our body is our body, but it is a trust from Allah subhanahu wa ta'ala. It is an amanat. So we can't talk about absolute autonomy. There are certain limitations, not only for treatment and things before, means end of life issues, even after death. When we talk about, nobody can say, okay, I want to be cremated, I don't want to be buried. You don't have a choice there, as far as the Sharia is concerned. So, you know, I think the issue of autonomy to what extent is a limited, scope, and I'm not saying very much limited, but there are areas which are beyond our bound. So it has to be looked at in a general capacity.
Does that answer? I think a lot of people were nodding. So does that answer, or is there something more you want to come back on that with any?
So I guess it does answer, and possibly it's still sitting uncomfortably because of the sort of the health beliefs I have and the way that I've been sort of taught to think about our health. But I guess what I'm saying is we are talking about active treatment, and active treatment can look different in different parts of the world. If I lived in a part of the world where peg feeding, to give an example again, wasn't available, then in that part of the world, I may not have that that available. And if I was to make an advanced decision that I don't want to be peg fed or have a ventilator, then is it not unfair for me living in this part of the world that I'm not, according to my Sharia, allowed to make that decision here in England when it is available? And I'm essentially saying I don't want to be actively kept alive.
I think if we can distill that question, it's been asked in previous palliative care seminars, which is, do we have to, as a patient, does that patient have the opportunity to deny a treatment that's available? Peg feeding, for those who don't understand, is when you feed somebody through their stomach as opposed to through their throat because of some sort of issue. Could we refuse that? Say, actually, this part looks, it's going to be painful, it's going to be uncomfortable, I don't want to do that part. I'm happy to let nature take its course. Or do we have to take whatever is available regardless because of our duty towards our Islamic faith and our belief?
Well, you say when it comes to the treatment or the issue of, let's say, feeding, of course, even there are limitations. Not everything is available everywhere, even where it's available. For example, when we talk about, feeding the person through the tube, that can't stay there for a long time. There's, a risk of infection and other things you guys know better than me. And so there are limitations there. So we are not saying that you have to go fully to the extreme situation. You will have to look at it case by case. But if there is a possibility of, feeding a person by other than the normal means, within, reasonable range, that would be wajib. But I think we have to go back to the situation of autonomy. To what extent? I don't like to do that, but I think a short answer would be, it's not my body, my business. It's my body, Allah's business. So we really don't have much of a choice there in everything.
I mean, this is a very interesting point which you made. Is actually our health beliefs are determined by how we are trained as well. And again, I challenge that notion a lot. My son is a doctor; he's a chest medicine trainee now, and were having this discussion about mesothelioma and how it has basically is a man-made disease. And how do we have subjected to those people who could live for so much, and now in the east of England you have got so many people are dying because we decided that they should die. Sorry, just for people's information, there is something called asbestos, which is which was used in 1960s and 50s in houses and industry, despite government knowing that it was causing mesothelioma, and government hid that all the way to 1967, and only then they made it public that actually it is. This is why they get the compensation paid now. So going back to the topic of the interventions that you do, a phrase I use in, again, not for Sharia, but in my teachings, is that just because you can do something does not mean you have to do it. My brother was a surgeon. He says the phrase commonly: a surgeon knows how to operate. A good surgeon knows when to operate, but a great surgeon knows when not to operate. And this is where the problem is, that just because we have got PEG available, PEG, which is the stomach tube which we put from outside, or any other intervention, what is our exit plan? We don't talk about. My talk last week in Finland was about that. We picked up in our research that the patients we put gastrostomy tubes and the NIPI, or the assisted ventilation, at the time of discussion, only 38% of the patient knew that it would be stopped at one stage. They thought it was forever. And when we were having that advanced care planning or discussion, we never put it to them, one day it will be stopped. And patients were turning around and saying to us in my research that actually, if I would have known it will happen, I would not have waited. So the offers we are making are based on, if I can use the word, and again, I use some provocative words, is half-cooked information. The treatments we are offering, are they really are we prolonging a patient's life, or are we prolonging a patient's dying? Meaning the process. And again, are we putting that on the table? Again, as a clinician, am I discussing that all when I'm doing that? And going back to not about Sharia, but from the clinical perspective, I find that one quite hard to understand, that when we did not have the information, why did we do that in the first place?
That's a really good point, and alludes to the complexity of advanced care planning. I'm going to take a Slido, then I'm going to come back to the ladies' side, and then I'm going to come back to the men. But we have Salah in about 8 minutes we want to be preparing, so what I said is not going to be possible. The question here is a really good one. Regarding withholding, withdrawing, refusing treatment, when is the trade-off point between treatments that can harm as much as they can help or cure? That's going to be for both of you.
If it's going to harm, of course, then it's not wajib to do that. It's difficult to give a general statement about it, but case by case, you'll have to look at the issue. Even chemo, for example, if it's going to be very painful and difficult for this person, then the person would have a right to say, no, I don't want to do it, go through it. Or even when we talk about feeding, if everything has been done, even if the person could be fed by the tube, but if the body is not absorbing it and accepting it, then you stop. Even though it means that, the person would die with, without nutrition. So when we say it is necessary to do whatever you can, that also has a limit there.
I think this is exactly the clinical view as well, that we will be withholding and withdrawing treatment based on the degree of harm that we are doing. For example, if they get a bit of vomiting with chemotherapy, that's different to causing so much neutropenic sepsis every week when they are doing that. And we know that they are not dying of, and I will share with you, my mother did not, mother's CA125 was normal when she died with ovarian cancer, but her white cell was 0. And she got an infection and she died. So.
Okay, I think I'm going to ask everyone to ask your question in about 15 to 20 seconds, and we're going to go for some rapid fire questions, and then inshallah we'll have Brother Hassan Jamal will recite Adhan, and we'll have the opportunity to pray.
Sorry, this was just following to the question just now. What if the patient decides to stop medication because the medication was not working in the past few years, but then once they decide to stop the medication, the organs start failing slowly? But then is it a possibility that with the medication that person could have lived longer?
Well, if the patient had used that medication before and it was not helping, then I think the patient would have a right to say no. Yeah, it is in the hand of the patient anyway to decide yes or no in that way.
But if the doctor is also seeing that it's not working, then he should be bringing that discussion anyway. It's not working. So any agent which we inject into you is not causing good, is more likely to cause harm. And as I said, that's
Okay.
what we see all the time.
Assalamu alaikum.
So,
Fadl Derry, retired consultant surgeon, 10 years in transplantation, 30 years in spinal injuries. Comment about the question that Maulana has asked. I'll try to answer it from a different angle. Yes, we do lack ventilators, but that's not the main reason from a surgical perception. We're always worried about what something we call warm ischemia time for organs. Organs need to be harvested quickly to keep them warm, otherwise they will die. They will necrose and die. Some organs are more sensitive to that than others. So for example, the liver, you have to harvest it before the others, while the kidneys may tolerate up to 15 minutes. The shorter the ischemia time, the more chance the organ will survive. So I would say the main reason why we moved in the definition is because of the warm ischemia time issue. This was a question that really faced the medical profession in the 60s, and they moved into the definition of into brain death because of the warm ischemia time issue. Because if we wait for the heart to stop and then we harvest, it's too late. Thank you.
Thank you.
fantastic insight. Thank you so much. We have, I think, time for maybe, please, a couple of quick questions, very quick.
Everything is available. But I'm sure you have come across, and as have we, that there are people who cannot afford even the basic curable treatment. Now, if I come across myself, for my own self, and I'm not talking about me trying to assist some who can, who need some kind of help, that is taken in charitable activities, whether it is wajib hukuk or ghair wajib hukuk. But I'm talking about my own dilemma. So I am caught between a rock and a hard place. I need to get this treatment done in order to live longer, to cure my disease. But for that, I will have to either beg or borrow. And I don't want to do that. What's the ruling here? I mean, am I right in making the decision that, look, I don't want to borrow. If I can afford it, fine. If I can't afford it, so be it. I'll die.
30 seconds, so. Okay. I remember this question was sent to Sistani in the question answer sections. Basically, we said wherever it's necessary, if they have the means, they have to go through it. If the family can support, then they have to support. If the family cannot afford the treatment, then the community should do it. But even if the community cannot do it, then of course nothing can be done. But your question is that I don't want to go and ask for donation. I don't think that would be wajib to go and beg for it.
Thank you so much. We're going to take our final question and then we're going to go to our break. But if you have got questions, I can see so many hands. I'm really sorry. It's so tough to say no. Please, if you use the Slido, and you all have the Wi-Fi now. So I'm going to ask Dr. Muhammad Bas Jaffer to speak. Great name.
Assalamu alaikum. I'm Mohammed Abbas Jaffer, a GP from Portsmouth and the Wessex Palliative representative. Thank you so much to both of the speakers. I found your talks very, very interesting and informative and instructive. My question is that we've heard one principle that there is a wajib duty upon us to essentially prolong the life where the means is available to us. On the other hand, we also know that when it comes to caring for a mayyit, we know that at that time the soul is going through a great ordeal. We've been taught things such as any pressure on the body itself, for example, is felt to a large extent by the deceased individual. So if that person has passed away, then something like CPR we would imagine would be an extremely traumatic experience, leave alone the physical aspect, which, as you mentioned, often includes the breaking of ribs, but also at a spiritual level as well. So how can we consolidate this? And as as an individual, must I resign myself to the fact that my life will end in this kind of significant trauma?
So are you talking about the linking that with the issue of retrieving organs from body?
So my question is that given that something like CPR would, by its nature is a traumatic process, is that something that, that we must undergo at the time of death?
Yeah, if you refer to that example of the reviving and CPR and, the ribs being breaking, again, it's a matter of, comparing a little bit of harm with a longer life. That's where you'll have to make the decision.
I'm referring more than the physical trauma, the spiritual trauma to, let's say, someone who has a disease.
That's really difficult to make any judgment about it. Neither the doctors can give you a measure for that, and neither nor any Maulana can do that. So we leave that out.
Inshallah. Are there any, related to this issue of CPR, are there any examples from the life of the Prophet or the Aimma alayhimus salam about, I've personally not come across examples where extraordinary measures were taken. For example, the one that you shared, the example of the seventh Holy Imam alayhi salam, who advised that the body be left for 3 days. In that situation, we didn't see extraordinary measures being taken, such as what we might have today as things like CPR or other things like that. Are there any such examples that we can see from the Holy Infallibles?
Not to my knowledge. I haven't really come across any example like that, because these are all kind of modern methods of reviving which didn't exist those days. So at least I have not seen anything like that.
Awesome, thank you so much. Thank you everybody for such an interactive and engaged morning session.